Hi, I'm Dr. Jack West, medical oncologist in Seattle, Washington, and I wanted to talk about a trial presented at ESMO 2017 that finally gives us some data, some evidence to speak to a question where we've previously had to rely just on our bias and our judgments. And this is the issue of you have a patient who has undergone potentially curative surgery for lung cancer, and do you follow them with chest x-rays? Do you do CT scans? And if you favor CT scans, do you want to do that every few months or less frequently? Does any of this make any difference? We have largely presumed that doing closer surveillance with CT scans is the way to go. That's certainly in many guidelines, but the guidelines around the world really vary because we haven't had high quality evidence to speak to this question. And we largely go by a presumption, at least in the United States, that more is better. So scans every 3 or 4 months, certainly every 6 months, are very common, at least in the first few years. But does that really make a difference? Well, Dr. Virginie Westeel and colleagues from France presented on a study called IFCT-0302 that directly tested this in a randomized trial. They enrolled 1,775 patients with resected non-small cell lung cancer treated for cure, and then they randomized them evenly between a minimal surveillance schedule that was just with chest x-rays and clinical exams, and then only a CT in the case of a patient having some symptoms that led to a concern, versus a maximal surveillance that included the same exam, a chest x-ray, but also a CT scan in regular intervals every 6 months for the first couple of years, and then annually after that, as well as even bronchoscopies in many patients, those with squamous or large cell non-small cell. Does that make a difference? Well, when you look at overall survival, the curves overlap going out many, many years, and there's no significant difference. If you look at 3 years and 5 years and 8 years, really there's no major difference in overall survival. And so the general conclusion from this is it really doesn't seem to matter about doing more intensive CT-based surveillance. However, when you look at the overall survival curve, you do notice that there is some separation later on, many years out. And that led the investigators to do an exploratory analysis where they just looked at the patients who hadn't demonstrated progression or relapse of their disease. And in that group of patients, they did see a separation that was statistically significant, favoring closer follow-up with CT scans. Now, that's an exploratory analysis, so we can't take that too far. But the authors did present in their conclusions the caveat that it isn't necessarily the case that CT imaging makes no difference at all. We do sometimes consider CT scanning not just in terms of a relapse of the old cancer, but in the potential benefits of finding a second cancer. Now, CT screening with low-dose CAT scans is certainly an approach that is recommended and has a survival benefit in patients at high risk. Patients between age 55 and 75 or 80 are routinely recommended appropriately to have an annual low-dose screening CT if they have a significant smoking history, because these patients are at high risk of developing a lung cancer. Now, the people who have already had a lung cancer that was treated with surgery are really by definition at high risk for another cancer, not just a recurrence of the prior one. So it really does make sense to focus on doing some form of screening for these people, at least with an annual CT scan, to assess for the potential for a new cancer. I have many patients who I've followed with annual CT scans for years after their surgery, not to look for the old one, but to find a new one. And I found many with a very early lung cancer who have undergone surgery or stereotactic radiation to the detected lesion. And to my recollection, all of these patients are without any evidence of the cancer coming back. And I am not confident that that would have been the case, that these patients would have done so well with a new cancer had we just relied on them to report symptoms. So this is still an open question, and it does question the idea of doing CT scans every 3, 4, 6 months in the first couple of years. There doesn't seem to be a major yield for that, but I don't think we should throw out the baby with the bathwater and say no CT scans post-operatively at all. This is also something where there is a cultural aspect to it, and I think it will require a change in our mindset, at least in the United States, about de-escalating the level of surveillance. But I think that we should follow the data that we have and at least cut back on the seemingly ritual-based CT scans that we often do, probably more than we need to. This is going to change my practice. It doesn't mean that I will stop doing CT scans in my post-operative patients, but I don't think I'll be inclined to do them as often. And I'm going to be confident that the evidence that we have shows that that's really not a high impact approach. I will continue to do annual screening CTs, and I've been happy to see the results of detecting so many early stage ones before they became more advanced. So that's my perspective. Of course, there's going to be a lot of interpretations of this. I'm interested in your thoughts.